Hello, I'm Bob Challoner, the President and CEO of Southampton Hospital, and I'd like to welcome you to another edition of Focus on Southampton Hospital, your monthly program about the events, happenings, and programs at your community hospital. And today I'd like to welcome a new member of our medical staff, Dr. Sampath Subramaniam. Dr. Subramaniam joined us last year as a surgeon and is specializing in bariatric surgery, joining our bariatric team at Southampton Hospital. So welcome, Dr. Subramaniam.
Thank you, Bob.
Very nice to have you here. And as always, especially with a new physician, tell us a little bit about yourself. I'd like to hear about how, let's talk about your clinical training and then how you ended up out here in Southampton Hospital. But let's start with your clinical training. So.
Thank you, Bob, and thanks to CTV for giving me this opportunity. I was born and raised in India, in Chennai, in the southern part of India.
Right.
I did my schooling and my medical school in Madras Medical College, which is one of the premier institutions
very
back in India.
well-regarded college, right?
That's right. And since then, I've traveled overseas. I've been in UK.
Right.
I did the FRCS at Royal College of Surgeons of Glasgow.
Oh, wow.
And I worked in New Zealand for about 4 years, and then I got the opportunity to come to the States. I did my surgical residency at Bronx Lebanon Hospital in New York.
Good.
And subsequently, I did my fellowship in minimally invasive, which is laparoscopic surgery, and bariatric surgery from Sinai Hospital of Baltimore.
Sinai in Baltimore.
Sinai in Baltimore. And subsequently, I worked in Bristol, in Connecticut, for about 1.5 years as a bariatric and general surgeon.
Right.
And now I'm here.
And I know that you had some family, your wife's in training also in the city.
That's right. My wife is doing a cardiology fellowship,
right.
and she's in Montefiore Medical Center, and she should be finishing this June, and hopefully look for jobs around.
Great. Long Island gets you a little closer together, I guess.
That's right. Yes.
Yeah. The fellowship in bariatric, how long a program was that?
It's a year's training. It's more focused into bariatrics.
Okay.
And also laparoscopic surgery. We did colorectal surgeries, we did laparoscopic hernia repairs, and also the bread and butter gallbladder and appendix and all those surgeries.
And that's after, what is it, 5 years of residency?
That's, yes, almost 6 years of residency.
Wow, wow. It's a long haul to become a surgeon, it certainly is. Yes. And I'm sure that our winter here, especially this winter, is a little bit different than Chennai, India. The conditions there, exactly. I don't even want to ask you how warm it is over there. I don't even want to think about it, given how cold it is outside right now. Hopefully by the time this is aired, the snow, the 2 feet of snow we have on the ground will be gone. So today we're going to talk specifically about bariatric surgery, and we've been offering, Dr. Medhat Alam's been doing bariatric surgery here at Southampton for a while, and he'll be joining us as another surgeon doing bariatric surgery, and I'd like to talk to you a little bit about that and about bariatric surgery. And first of all, let's talk about the obesity epidemic in the nation, and certainly I always am interested. We've heard a lot about it over the last couple of years about how Americans are dealing with this obesity epidemic, and just wanted to get your thoughts on maybe what you think maybe is happening out there.
Right, yeah, the obesity is certainly becoming a huge problem in the United States. It's not only in the United States, it's a pandemic. It's all over the world now. About 80 million adults are obese, and nearly 12.5 million children are obese. Right. This is a huge problem, not only in terms of the economics, but in terms of the overall health scores for all our patients. Now, I mean, the obvious reasons for these is the fast food culture that we're kind of getting into, which we'll talk more about. Right. But it is a multifactorial condition, and it's not that everybody who takes a burger is going to become obese. Right. There are a lot of factors that play into this, but certainly it is a huge healthcare problem.
And one of the terms that we hear, and where bariatric surgery particularly is, it's an important term, is morbid obesity, which sounds pretty ominous, but what exactly is morbid obesity? How do we define morbid obesity?
In simple terms, obesity is abnormal accumulation of fat in the body. And morbid obesity is accumulation of fat to the extent that the health is impaired.
Okay.
So when the body weight becomes a problem for the patient, when it leads to comorbidities like diabetes and hypertension and heart disease, then we talk about morbid obesity. The tool that we usually use is BMI, or the body mass index, and if the BMI is above 40, that's technically called as morbid obesity. BMI about 30 is obesity, okay, and BMI between 25 and 30 is called overweight or pre-obesity.
Can you just explain in very simple terms BMI? I know we bandied that term around a lot, and a lot of us talk about BMI, but just for people that may not understand exactly, what is body mass index?
So BMI is weight in kilograms in the numerator divided by the square of the height in meters.
Okay.
As you can see, the shorter you are, the BMI goes up pretty quickly.
Okay.
Because the denominator is in a square.
Okay.
So for the same body weight, if you're a shorter person, your BMI can be really high.
Okay.
And as I already mentioned, BMI above 30 is generally technically termed as obesity.
Is there an ideal body mass index calculation?
Usually around 22 is the BMI that's technically ideal, between 20 and 25. If you are below 19 and below, it's probably underweight. BMI of 20 to 25 is the recommended body weight.
Okay. So as we start to look at people that are obese and tending toward morbid obesity, who should consider bariatric surgery?
Well, as far as I'm concerned, anyone who's obese and who is uncomfortable with it, who feels that they need that corrected, who have attempted multiple ways in the past to deal with it and have been unsuccessful, and who are candidates for surgery are pretty much candidates for bariatric surgery. However, we do have what's called as the NIH criteria, which is the National Institute of Health.
Okay.
They placed this criteria way back in 1991, and still the insurance companies use the same criteria. There are a lot of new evidence that has come in to include more patients, but we still go by this NIH criteria. And that is BMI of 40 and above, or BMI of 35 and above with an obesity-related comorbidity, like diabetes or hypertension or sleep apnea.
Okay.
And anyone who's attempted non-surgical weight loss and have failed on those, and those who are good candidates for surgery.
Okay. And what are, we'll talk about the surgery a little bit, about how it's done also, but in terms of those criteria, and I know that there are different criteria. Sometimes insurance companies differ a little bit. Medicare can be a little bit different. Roughly, or what are the sort of age ranges that can be considered, and some of the other major limiting factors around who could be a candidate for surgery?
Right. Ideally, anyone who is who's mobile, who's not limited by their mobility, who can understand what the pros and cons of the surgery, and who can follow with the protocols that are necessary to maintain the weight loss, and who are not in the extremes of age, who do not have organ failures or who are transplant candidates, who do not have extensive cancer or other terminal illnesses. Most of these patients qualify for bariatric surgery. Okay. However, in a community hospital, we kind of keep the age limit between 18 and 60. Okay. This is a voluntary kind of restriction, right, so that we have safer outcomes here.
It's because as you become older, surgery becomes riskier after a certain age.
That's right, yes. Right. And also obesity is like a symptom. It's not like a disease that needs an immediate treatment. The effects of taking care of obesity is going to be apparent in terms of mortality and morbidity after a few years.
Okay.
So if they do not have that longevity after the operation, if they are not expected to survive more than 5 or 10 years, then obesity surgery is probably superfluous for those people.
Okay. And below a certain age, it's the same issues, I guess. There's well, not certainly in terms of longevity, but in terms of certain riskiness in a community hospital may not necessarily be something we do.
Exactly, yeah. There are specialized centers that deal with adolescent and childhood obesity.
Okay.
That's probably the best places to deal with those.
Okay. So before we talk specifically about types of surgery, but let's talk about the benefits, and once somebody, clearly losing weight's a benefit, but what are the other benefits from bariatric surgery?
Right, I mean, losing the weight, as you said, one of my patients described it like a butterfly coming out of a cocoon. Right. They feel so free after they shed their weight off. It's also the energy levels are much higher, and their self-esteem improves. They're more confident. Their social interactions improve, their performance at work improves. So it literally changes their outlook completely. Right. And they are extremely happy after the surgery. The medical point of view, there are comorbidities that obesity is associated with. And those can be reversed, like diabetes and hypertension and the heart disease that it leads to, sleep apnea and respiratory problems that it can lead to. Liver diseases like steatosis. So it does affect a wide range of situations, including osteoarthritis from weight-bearing joints. So all these can be reversed after bariatric surgery.
I know that people do struggle with hip and knee problems when they're as a result of
obesity. That's right, yeah, because of the weight, their wear and tear is much earlier than what it should be for their age. And that can be reversed after bariatric surgery. Okay,
well, let's talk a little bit about the types of procedures, and there are multiple kinds of bariatric surgery. Maybe you could explain each of the major types of surgery, and if there's a sense of which you prefer or who may be good candidates for which type of surgery.
So there are typically most people offer 3 different bariatric procedures: the lap band, and the sleeve gastrectomy, and the gastric bypass. Okay. There are a few centers which offer other procedures like duodenal switch, which again need a closer monitoring of patients and would need a specialized center. Of the 3, I do not generally specify to the patient as to what procedure they need, as long as they do not have any medical contraindications. Okay. It's the patient's choice. Most people have their friends or relatives who's undergone a particular procedure and would prefer that. I'm okay with that. But if there are certain
You're able to do all 3 of them?
I can do all the 3 of them. Right. As long as there are no medical contraindications for a procedure. For example, if the patient is taking steroids, I wouldn't like them to have a lap band because it's a foreign body and it can get infected pretty easily if they are immunosuppressed. Oh, really? If someone's on smoking or taking chronic NSAIDs, they can develop what's called as marginal ulcers if they undergo a bypass. So in those patients, I would rather say, why don't you go for a sleeve or a band? Okay. If someone had a gastric ulcer or a duodenal ulcer that's long-standing, they're probably better off with a bypass than a sleeve. Oh, really? So there are certain group of patients who probably I would advise them against a particular procedure. Okay. But if they don't have these comorbidities, then it's their choice.
And I would guess that you have to work very closely with the patient's primary care physician in order to really understand their full medical history when you make that determination.
Exactly correct, yeah. So we need their full past history, and we get in touch with the primary care. Right. And also, the primary care doctor has to write a letter of medical necessity, which is part of the insurance package that we have to forward to get the approval in the first place. And of course, after the operation, they have to go back to their primary care for follow-up and So we work really close with the primary care doctors.
Now one of the questions I have is that sometimes people who are suffering from morbid obesity have a lot of other health problems. Do you have to do anything to sort of tune them up before the surgery? I mean, because there's a riskiness already for some people that may be sick as a result of being overweight for so long.
That's correct, yes. Obesity does pose significant risk in terms of surgery because of the high blood pressure and the diabetes, the heart conditions, and the respiratory conditions. Right. And also in terms of positioning the patients during the OR because of their body weight. Their increased thrombogenicity, they can develop clots and which can shoot to the lungs. Okay. So they are a high-risk category, and we do put them, so to speak, through a number of tests. Right. So I send them out for cardiology, pulmonology, and anesthesiology and psychiatric clearance. Okay. And also do lab studies, and we do X-rays and EKGs. Mm-hmm. And they also undergo an endoscopy. If they're undergoing a sleeve or a bypass, I would look into their stomach as well. So they go through all these kind of rigorous testing before they come to the table. Okay. We have to ensure that they can undergo this procedure safely.
Right, because surgery is, any sort of surgery is tough on the body, so it's something we always have to be careful
That's
about.
Correct,
That's
yes. Right. Although bariatric surgery is being done laparoscopically, right. And so the trauma to the patient is much lesser, right. But we would still, want them to be in their best shape.
Let's talk about that laparoscopically. What does that mean exactly for people that are right. not medical people?
So laparoscopic surgery is basically done through small, tiny incisions. And when they heal up after a few months, they are virtually scarless. Okay. Now, it's not just the cosmetic advantage, of course. Right. Anyone who has a big open procedure with a big cut in the midline, their complications related to the wound is much higher, like wound infections, adhesions, where the intestines get stuck to that incision, and they can get kinked and cause bowel obstructions in future. They can also develop hernias. Apart from these, there is much lesser pain because of the tiny incisions. There is less fluid loss and less heat loss right. For someone who's undergoing laparoscopic surgery compared to open. Okay. And what that means is the inflammatory mediators that happen after the trauma of the surgery are much lesser. And with the lesser amount of pain, the amount of painkillers they're needing is much lesser. Okay. And the amount of fluids they need to be resuscitated is lesser. So all this combines to their outcome. So they're going to recover much quicker right. Because the trauma is much lesser, so their intestines recover quickly, their lungs recover quickly, right. And also they don't form as many clots. Okay. So all these are beneficial to the patients, okay. And they go home much quicker than after an open operation.
Is there an overnight stay with laparoscopic surgery?
It's for sleeve and bypasses, yes. They usually okay. stay about a couple of nights. Okay. The bands can be done as a day case. They can okay. come in and go home the same day. Although initially I keep them for one night okay. Just because most of them have some pain or nausea, right. and just for their comfort really. But they can go home the same day after lab band. I'd
like to talk a little bit, if we could, about the three types of surgery, and just in very simple terms, what is a band, what is a sleeve, and what is bypass? So. Right.
So a band is essentially a silastic ring. It's like okay. a plastic ring that is lined on the inside with a balloon. Okay. And it connects via tubing to a port that we place just under the skin. Okay. So this goes just on the topmost portion of the stomach, just below the junction with the food pipe. Okay. And once we place it, the diameter can be adjusted through the port. We can okay. inject some fluid in and remove some fluid, and thereby adjust the balloon thickness, and so the amount of constriction on the stomach. Okay. So its main purpose is restriction. Okay. So as soon as they eat a bolus of food, it just doesn't pass into the stomach easily. It okay. gets held up in the upper portion of the stomach. Okay. And so the patient gets this feeling of being full. Okay.
I'm envisioning sort of like one of those long balloons you see at the fairs where they're tying off sort of the top end of it, or constricting the top end.
It's like it's like a ring around it.
Okay.
So essentially that's how it works. But the important thing about the band is it is going to take a few sessions of filling before it gets to the point where it's going to start helping you lose weight.
Okay.
The reason being the stomach can react adversely if we go ahead and fill it up in one quick go.
Okay.
The stomach doesn't like being choked, just we wouldn't. So the stomach would vigorously react, and then it may slip, the band may slip down from its position that it's intended to be.
Okay.
So to avoid this, we have to incrementally fill the band.
Okay.
And that takes a few sessions, and so that means the weight loss begins to happen some people about 6 months or so after the procedure.
Oh, really? Wow. So it's quite not as if somebody hoping for a quick reaction.
That's right. For a quicker reaction, the sleeve or the bypass is probably a better option if that's what they choose to. Now going back to the advantages of a band, it's a much simpler procedure compared to the sleeve or the bypass.
Okay.
And so the perioperative morbidity is lesser, and they go home the same day, as I did mention.
Okay.
Also, there is no breach to the intestinal tract.
Okay.
So, and so the most dreaded complication of bariatric surgery is leaks.
Okay.
And since there's no breach, there's no leak in bands.
Okay.
So that's a big advantage.
Right.
Also, it is removable. The band can be removed if the patient, for any reason, wants it out, or if there are medical indications, we can go in and remove it.
Okay.
And it's adjustable even in the long term. The nutritional complications are slightly lesser compared to a sleeve or a bypass.
Really?
So those are the main advantages. The disadvantages of band.
If you can open and close the band, can you adjust for people too? I mean, if
that's right. Yeah, that's why we have the sport.
Okay.
So this is just under the skin, and all we need is a tiny needle, a specialized needle that goes in, and we can suck out the fluid or put in more fluid at any time.
Oh, okay.
Yeah.
So you can somewhat regulate the weight loss over
exactly.
time.
Yeah, over time. Having said that, the main drawbacks, though, is it produces the least amount of weight loss compared to all the three.
Oh, okay.
The weight loss is typically around 40 to 50% of the excess weight.
Okay.
Compared to a sleeve or a bypass, which is about 60 to 70%.
Really? Wow.
But it's much better than just dieting.
Right.
And the other disadvantages are the band slippage that I previously said. If we had to keep constricting it a bit too much than what the stomach can handle, then the stomach reacts adversely, and then the band tends to slip down.
Okay.
In which case you may need another operation to reposition it.
Okay.
Also, a tight band can sometimes erode into the stomach.
Oh, okay.
That's called as a band erosion. Sometimes there are device malfunctions, although this company is very reputable and they made millions of bands with very little faults, but potentially that could happen. And a band infection, once the band infects, it's a foreign body and it needs to come out. Okay. There's another operation involved if it gets infected. So these are the main kind of drawbacks of having a band.
Does the band stay in for the rest of a person's life?
It could, yes. As long as it doesn't get infected, it can stay there for the rest of the patient's life. And it can be adjusted for the same reason anytime that they want in future too.
Okay.
That's the advantage. In terms of sleeve and bypass, the bypass is an operation where the stomach is cut into a small pouch, and it's directly connected to the distal portion of the intestine. Okay. So the food passes from the food pipe into this small upper portion of the stomach and then goes into the distal small bowel.
And what happens to the rest of the stomach? It just sits there?
The rest of the stomach is just sitting there, and it connects to the initial portion of the intestine, which is where the bile and the pancreatic juice and all the digestive enzymes are formed. Okay. And then they come down further down and then connect to the main stream. Okay. And that's where they add the juices. So the full digestion takes place only in the last portion of the intestine. Oh, I see. And that's an advantage in terms of weight loss, because it not only restricts the amount of food, but even that little amount is not fully digested and absorbed. Okay. So it's a double stage weight loss procedure.
Okay.
As opposed to sleeve and band, which are purely restrictive.
Right.
Also, the bypass has hormonal effects, which have recently surfaced. There are a lot of researchers going into it. And one of the biggest advantage of the hormonal effects is that the metabolic rate, the resting energy expenditure, is actually going up with bypass, even though they're eating lesser.
Really?
That is a big difference compared to the band and just dieting, because when you diet, the body tries to conserve energy.
Right.
Because you're putting in less energy, so the body thinks that there's not enough energy, I have to conserve. So what it does is basically you're slowing down. You're feeling sleepy all the time, you're not able to concentrate, you're not focused, you're lethargic. And all if you fast for a few days, actually, your blood pressure can go down, your respiratory rate, your pulse rate can all go down, intestine slow down. So
I've heard that that's a challenge with weight loss. People that go on these severe diets, they slow their metabolism down.
Exactly, yes.
And then you need to, as soon as you eat more, suddenly your body's operating at a slower metabolism, so you tend to put weight back on.
Put weight back, yeah, exactly.
Okay.
And that's why dieting has been so frustrating for people. Whereas with bypass, the hormonal effects are such that you are restricting your diet, but at the same time, you're increasing your energy expenditure.
Okay.
So the weight loss is very quick.
Okay.
If someone is a bad diabetic, bypass is probably the best procedure.
Is it? Okay.
If someone has a bad reflux,
right.
With acid going up their throat, again, bypass is a good anti-reflux procedure.
Okay.
So that's probably the best procedure. So anyone with a high BMI who has bad reflux or diabetes, who are not on NSAIDs, who are not smokers, bypass is probably a good option for them. Sleeve, I would place them somewhere in between.
Right.
So the sleeve is a slightly less involved procedure compared to the bypass, and hence the perioperative complications are slightly lesser. But it is relatively more involved than the band, so I would put it somewhere in between. The weight loss is pretty good. It's almost 60 to 70% weight loss, almost comparable to the bypass actually. And there are hormonal effects with sleeve as well, because the fundus, which is the baggy portion of the stomach, that is responsible for producing a hormone called ghrelin, which is a major hunger hormone that gives you that sensation of hunger all the time. Ghrelin? Okay. So since that baggy portion is off, they don't feel that hunger anymore. So that's an important advantage with sleeve. The disadvantage is the long staple line, and that can open up at some spot and can leak at times. And if they leak, it is an important complication. They may land up being sick. But these are extremely rare. Most people do very well.
So the sleeve procedure is also much more surgical, obviously, than the band, but not as
involved as the bypass. I would put it in between the band and the bypass.
Okay, great. And how quickly would you expect to see weight loss happen with any of these? You already said that with the band it's a little slower. It can be 6 months or so. The sleeve and the bypass, is it pretty rapid weight loss?
Yeah, they pretty much start losing weight almost at the time of surgery. The weight loss peaks between 6 months and 1 year. They can lose, I would say the sleeve is around 60–65% of their excess weight. And bypass is close to 70–75% of their excess weight. We do have studies with bypass going as far as 15 years with data showing that they do maintain over 50% of their excess weight for as long as 15 years. So there is very good data with bypass. With sleeve is a relatively new procedure, so we do not have very long-term data. But up to 5 years, they do maintain excellent weight loss.
And I know we're almost out of time, unfortunately, but do you recommend additional support, nutritional counseling, or supplements, or is there additional things like that you would recommend for somebody once they've had the surgery as well?
That's correct, yes. We do have a dietitian who works with us. In terms of multivitamins and nutritional supplements, they will need 1 or 2 tablets based on the type of the surgery. And also they will need calcium citrate and vitamin D3 and vitamin B12 as well.
Right.
And they should take care of the protein intake. Because if the proteins are deficient as a result of the restricted amount that they can take, they can go into protein energy malnutrition, which should be avoided. So we recommend that they start off the plate with protein containing food. Usually around 60 to 80 grams of proteins per day is recommended.
Right.
They should also take a lot of fluids, 50 to 60 ounces of fluid per day. And once they have had the protein, the next thing they take is the vegetables and then the fruit. Leave the carbs and the fat to the last, or if possible.
Seems like we should leave those out under any circumstances. Exactly.
Yeah.
Great.
So we have a dietitian who will be able to follow through with them, and they can correspond through email or they can call her. And certainly ask whatever questions they have, and I'm available to counsel them.
Great. Well, Dr. Subramaniam, thank you so much for being with us today and joining our staff, and a great addition to our community. And I know there's a lot of people out there who need help with weight loss, and the options you're providing are absolutely wonderful. And I'd like to thank all of you for watching, and if anybody has any questions, would like to contact Dr. Subramaniam, learn more about him, or make an appointment with him, he can be seen in the Schenck building at 240 Meeting House Lane, adjacent to the hospital. The number for an appointment is 631-726-8717. And I know that Dr. Subramaniam would be very happy to hear from any patients that may be considering surgery. I'd like to thank all of you for watching today. I'd like to thank our friends at CTV for producing and airing the show in Southampton, our friends at LTV, of course, for airing our program in East Hampton. If you have any questions, would like to learn more about bariatric surgery, need help navigating the healthcare system here on the East End, or just need advice on how to find a doctor, please call my office at 631-726-8555. We'd be very happy to help you out. Also, if you have any ideas for future programs or questions, please feel free to give us a call. Thank you very much, everyone, and good health.